Hi, I'm Dr. Tom Kravis, Physician Executive for 3M Consulting Services. Thank you for joining me. Today we're going to talk about ICD-10 documentation for mental and behavioral health. There are some changes you'll need to make in your documentation to support ICD-10, but there are instances of documentation that can remain the same. Let's get started. We will review this information today, which will help relieve any anxiety you may have about ICD-10 in the future.
I know you are busy in your clinical practice, so I will briefly summarize the key takeaways. In your documentation of patient care, consider the use of adjectives and link the cause and effect of each condition. Be specific about aspects of a disease and use exact dates when appropriate. A little more on each of these. Differentiate in your notes whether or not a condition is acute, chronic, or acute on chronic whenever appropriate. For example, document chronic post-traumatic stress disorder instead of post-traumatic stress disorder. Use due to or secondary to indicate cause and effect and to record all conditions the patient may have, such as dementia due to Alzheimer's disease. Think about the most current terminology to describe a condition or different aspects of the disease. For example, dementia due to Alzheimer's disease with wandering behavior. Use exact dates when appropriate. For example, patient with vascular dementia due to stroke 6 months ago. Ask yourself, what else could I add in my notes about this patient's condition that would better communicate how sick the patient is, which in turn better communicates the resources needed for patient care? Incorporating these aspects into your documentation will result in an accurate picture of your patient's severity of illness and risk of mortality. This in turn will result in accurate public reporting on quality and outcomes. And it will help reduce the number of queries you receive to clarify your documentation. In the upcoming slides, we'll take a look at some diseases and procedures that have new documentation requirements under ICD-10. What's new in ICD-10 for alcohol and drug use, abuse, and dependence? ICD-10 provides combination codes to report the use, abuse, or dependence of alcohol and drugs, along with any associated manifestations such as dementia or psychotic disorders. There are many more codes available in ICD-10 to identify specific manifestations associated with substance abuse and dependence. It is important to specify in your documentation whether the patient is an abuser of or dependent on the substance or substances. If you only document use, such as in cocaine use, the condition will be coded as cocaine use unspecified. Specify in your documentation if the patient abuses alcohol and/or drugs or is dependent on them. A diagnosis of use is reported as unspecified if abuse or dependence is not specified. In this example, we see documentation of cocaine and alcohol use without further specificity. Improved documentation includes the terms abuse or dependence. Again, first and foremost, specify substance abuse or dependence. If the patient is acutely intoxicated at the time of the encounter, there are ICD-10 codes that indicate this. In the case of acute alcohol intoxication, record the blood alcohol level if known, as there are now codes to capture this information. Indicate in your documentation if alcohol or drug-dependent patients are currently in remission, as ICD-10 provides codes to capture this status. Code assignment for remission is based on your clinical judgment and must be documented in medical record. Additionally, you should document any of the disorders or complications of substance abuse or dependence that the patient may suffer from. ICD-9 provided a single code for tobacco abuse and dependence without differentiation and without further specificity for the type of tobacco product. ICD-10 provides separate codes for these. If your intended diagnosis is dependence, dependence is what you should document rather than abuse. According to the Centers for Disease Control and Prevention, most smokers are dependent, and nicotine dependence is the most common form of dependence in the U.S. Additionally, further specificity is provided in ICD-10 for the type of tobacco product dependence, as cigarettes, chewing tobacco, or other, for example, cigars, so this should be documented as well. Your documentation should differentiate between current abuse or dependence versus a person who no longer uses tobacco. Starting in 2002, the number of former smokers has exceeded the number of current smokers. For tobacco dependence, ICD-10 provides the ability to report remission and withdrawal. Examples of nicotine withdrawal symptoms include irritability, anxiety, difficulty concentrating, and increased appetite. ICD-10 also provides the ability to show a cause and effect relationship between tobacco dependence and nicotine-induced disorders when documented. Finally, your notes for a patient's exposure to secondhand smoke can be converted to an ICD-10 code that says exactly that. What's new here is that a diagnosis of depression without further qualification is coded to F32.9 in ICD-10, which is the code for major depressive disorder, single episode, unspecified. In ICD-9, a diagnosis of unqualified depression was assigned a code that simply stated depression. If your intended diagnosis is something other than major depression, such as depressive neurosis, anxiety depressive disorder, bipolar disorder with depression, or an adjustment disorder with depression, document this in order to avoid inappropriately classifying the patient as having a psychosis when they don't have that condition. If the patient does have a major depressive disorder, consider adding additional details to your documentation about the condition. For example, major depression can be further specified as being a single versus recurrent episode, as well as being in partial or full remission. In addition, it can be categorized as mild, moderate, or severe episode, and if severe, with or without psychotic features. There's not much new with schizophrenia codes in ICD-10, other than a few code title changes, as well as some reorganization of codes. The type of schizophrenia should be specified as outlined on screen, such as disorganized or paranoid. For patients who suffer from schizoaffective disorder, the type should be specified as bipolar or depressive. The ICD-10 codes for mood disorders include major depressive disorder, which we discussed previously, as well as bipolar disorder and manic episode. Mood disorders will continue to require specific documentation about the current episode in ICD-10, much the same as was required in ICD-9. That is, whether the patient is manic, hypomanic, depressed, or has a mixed presentation, and if in remission, whether it is full or partial. If the patient has evidence of psychotic symptoms, that should be documented as well. In addition, the severity of the presentation, mild, moderate, or severe should also be recorded. Lastly, it should be noted if this is a single or recurrent episode. These documentation requirements are identical to those for major depressive disorder and are important to capture in order to present an accurate picture of the patient being treated. Post-traumatic stress disorder, PTSD, is estimated to affect 7.7 million adults in the United States. Effective treatments have been developed, and research into prevention methods is currently ongoing. What's new with post-traumatic stress disorder in ICD-10 is that it is now categorized as acute or chronic PTSD, which you'll be required to indicate in your documentation. This differs from ICD-9, where there was only one code available for PTSD without further specificity. Specifying the chronicity of the patient's PTSD will assist in gathering accurate statistics, which will in turn aid future research on treatment and prevention strategies. As physicians are increasingly held accountable for patient outcomes, a huge concern is how to classify the patient who fails to follow a recommended regimen of care and gets sicker as a result. Under ICD-9, there is only one generic code for such a patient that says non-compliance, and no additional detail as to why the patient didn't follow your instructions. But in ICD-10, there are several codes to describe why a patient is non-compliant in taking drugs prescribed by you. This new clinical terminology is drug underdosing. Underdosing identifies a situation in which your patient has taken less of a medication than prescribed by you, either unintentionally or intentionally. Document in your notes why the patient isn't taking the correct amount of their medication and the associated condition. For example, patient was admitted due to poorly controlled type 2 diabetes mellitus. Patient has age-related dementia and forgot to take her metformin as prescribed. Or patient stopped taking her lithium because she doesn't like the way it makes her feel. In the next few slides, we'll cover the ICD-10 aspects of some of the more common medical conditions associated with mental and behavioral disorders. ICD-10 uses the term hepatic failure instead of hepatic encephalopathy. Additionally, ICD-10 provides for the ability to distinguish between acute or subacute and chronic hepatic failure, and with or without coma, which when documented will allow the reporting of how sick your patient is. Additionally, codes are provided for hepatic failure due to drugs, which you are encouraged to specify. It has been my experience that physicians often document the signs and symptoms of hepatic failure, for example, confusion, altered levels of consciousness, or coma, without actually documenting the underlying condition itself. So if your intended or suspected diagnosis is hepatic failure or hepatic encephalopathy, that is what you should document in your notes. But you also need to specify whether it is acute or chronic, with or without coma, and specify the etiology of hepatic failure, such as alcohol dependence. Obviously, it's appropriate to include the signs and symptoms in your notes, as long as you also include the diagnostic terms of hepatic failure or hepatic encephalopathy. ICD-10 provides several new codes for specific types of pancreatitis, such as idiopathic acute pancreatitis and alcohol-induced acute pancreatitis, while continuing to distinguish between acute and chronic, as was the case in ICD-9. However, there are continuing opportunities for improvement in the documentation of acute versus chronic pancreatitis and the specific etiology. Let's take a look at some actual medical record documentation on the next slide. We see here in this example of medical record documentation a final diagnosis of pancreatitis and alcohol abuse. There is no statement of acute versus chronic, and there is no linkage between the pancreatitis and alcohol abuse. The final diagnosis on the right tells a better story. It clearly states the pancreatitis is acute and shows cause and effect by stating due to alcohol dependence, which results in the reporting of alcohol-induced acute pancreatitis. The coder is not permitted to assume the alcohol caused the pancreatitis. Only you are able to document and use words such as caused by, due to, or secondary to. Additionally, consider the statement in the history, daily alcohol use. If your intended diagnosis is alcohol dependence, state dependence rather than abuse or use. Dependence and use or abuse are two different codes. Malnutrition is an underdocumented condition in the elderly. However, it is also an important indicator of your patient's severity of illness and an important influence on performance metrics such as readmission rates, length of stay, and quality outcomes. If your patient has malnutrition, you should document the clinical picture, the type, such as protein calorie or protein energy malnutrition, and the stage or degree. For example, mild, moderate, or severe, or first, second, and third degree. Your notes should include clinical findings such as patient with terminal cancer, 20-pound weight loss, and cachexia, and any supporting labs such as low albumin. We'll take a look at a few procedures that may be performed to give you some exposure to ICD-10 PCS codes and associated documentation requirements. What's new with substance abuse treatment? In ICD-9, there are codes for drug or alcohol or combined drug and alcohol detoxification, rehabilitation, or both. In addition, there is a code for drug addiction counseling as well as alcohol counseling. In ICD-10, there is a whole suite of codes for substance abuse treatment. These codes can be grouped into three categories, with the first being detoxification services for alcohol and/or drugs. The second group of codes classifies counseling, including individual counseling, group, and family counseling, as well as individual psychotherapy. The last group of codes identify the use of replacement medication for the treatment of addiction, as well as the monitoring and adjustments of those medications over time. It will be important for you to document the type or types of counseling provided. For example, 12-step or confrontational. The options for the types of therapy can be seen on screen. In addition, the replacement medication you prescribe for treatment or manage on a follow-up basis should be clearly identified as well. In ICD-9, there was only one code for electroconvulsive therapy, ECT. In ICD-10, there are more code options for ECT, requiring you to specify in your procedure note whether the ECT treatment is unilateral or bilateral, and if it consists of a single or multiple seizures.
ICD-10 requires more detailed descriptions in your documentation of anatomical site and aspects of a disease, condition, procedure, and circumstances of patient encounters. The information generated from ICD-10 codes will result in a more accurate picture of your patients, their severity of illness, risk of mortality, and the services rendered. This in turn will result in accurate public reporting on quality and outcomes. Should you have questions about documentation for a particular diagnosis or procedure, your hospital's clinical documentation improvement specialist should be your first stop. The coding staff in your Health Information Management Department is a valuable resource as well. Thanks for joining me, and have a great day.